Hi, and welcome to our live webinar. Today we have with us Dr. Perez, and he is the director of the Functional Neurological Disorders Clinic at Massachusetts General Hospital. Dr. Perez provides specialized integrated neurological and psychiatric consultations for patients with FND. He's also the director of their Functional Neurological Research Group, and we're really excited to have him with us here today. Dr. Perez?
Hi, everyone. It's a pleasure to be with the group. I'm just going to check in with Bridget. Bridget, can you hear me okay?
I can hear you okay, and you're live. And I believe we even got our Facebook to work. So hopefully we're all set to go. I'll just turn the time over to you. We're really excited to have you here. And you're going to tell us about some of the research that you have going on. And it's been really a huge topic within the Facebook groups. And there's been questions of, this has always been a software problem, but perhaps is this maybe also a structural problem as well? And we're hoping that you'll be able to help answer some of those questions for us today.
Very happy to try to tackle some of these issues. I think to begin, my compliments to FND Hope, to Bridget Milden. It's so exciting to have a World FND Week. There's a tremendous need, as many patients who are listening in know well, and those of us who do clinical work and research, we're energized to try to make a difference. And I hope over the next 15 to 20 minutes to share with some in the audience some early phase research. And so let me go ahead and share with you my slides. And in particular, the focus of the next few minutes is a recent JNMP article highlighting functional connectivity profiles in patients with functional neurologic disorder. But I'm also happy to take a few questions at the end with regards to this issue of a software versus hardware problem that we can engage in a discussion on. It may be a bit of both, but we'll get there towards the end. Let me make sure my slides can advance. Sorry for some technical difficulties. Hopefully we'll. Great. So these are my disclosures. And in particular, as we begin, I really want to be immensely thankful to my clinical and research team, who without their diligent work and collaboration, this would not be possible. And in particular, I'm going to be highlighting the work of a postdoctoral research fellow, Dr. Ibai Dez, who's been very talented in executing many of the complicated neuroimaging analyses that I'm about to digest for the group in a few nuggets. I think it's important as we start to share with those who are listening my own perspective on functional neurologic disorders. And this is one that integrates both a neurologic and psychiatric perspective, a holistic, integrated clinical neuroscience perspective. And this is the perspective that we take in our clinic, as well as in the kinds of questions that we're asking in our research program. And before delving into some of the details of the functional neuroimaging findings from our most recent study, I think a few important caveats as we start. We all know that functional neurologic disorder is incredibly complex. And I'd like to highlight that it's markedly understudied in comparison to major neurologic and psychiatric conditions. We're all energized and we're working very hard, but I think it's important to note that we're early phases in beginning to understand the biological mechanisms of functional neurologic disorder. With all research, replication and additional clarification is important, and this is certainly indicated for the work I'm presenting here as well. The other point to highlight is that with the brain imaging fMRI research that I'll be speaking about over the next few slides, this is a kind of analysis that isn't clinically available, and nor is it clinically indicated. So the goal of our research program currently is to use math algorithms to try to understand connectivity profiles, brain symptom relationships, and delve into the biology with the hopes that in the future, we can help push the boundaries of making this kind of clinical imaging more relevant. This is a bit of a snapshot of how early phase we are in the field. So you can see that in 2019, we conducted this search just yesterday to really share with the audience how early we are in the use of neuroimaging to study functional neurologic disorder. So in comparison to multiple sclerosis, Alzheimer's disease, major neurologic comorbidities, we can see that there's tens of thousands of neuroimaging articles in these populations. There are similarly several thousand articles in major psychiatric conditions, such as major depression and post-traumatic stress disorder. And we're in the single digits, or at least several dozen studies in functional neurologic disorder, really highlighting that we have a long way to go, but we're looking to push these boundaries. My own group has been interested in the biology of functional neurologic disorder for about the last 7 to 10 years. And we think of functional neurologic disorder based largely on excellent work done by others in the field previously as a multi-network problem. Several core brain networks interact in abnormal ways, the software problem, to potentially produce the constellation of symptoms that we see in patients with functional neurologic disorder. The network of interest for this webinar is highlighted in purple. This is largely the salience network that includes the insula, the cingulate cortex, the amygdala, and some brainstem structures as core portions of the salience network. I should note that this is an oversimplification. And in fact, there's been some excellent work recently by Susanna Pick out of the UK, really advancing the model with an emphasis on emotion processing. And you can see that it's orders of magnitude more complex than the early phase diagram that I showed previously. And I'll direct the audience to this nice article for more details. As we think about the salience network was initially characterized by Bill Seeley in an excellent article in 2007. And again, showing with white circles, the insula is traced out in the top portions of this slide. And in yellow, you can see the cingulate gyrus and the dorsal anterior cingulate in particular. These are two of several core components to the salience network. To delve a little bit more into the insula, which is a particularly important brain area that my group is hypothesizing is implicated in the pathophysiology of functional neurologic disorders, and others have contributed to this literature as well. We think of the posterior or back portion of the insula as involved in developing a representation of how we feel in our bodies. The middle portion of the insula receives information that has emotional and motivational value. And it's the front or anterior portions of the insula that look to bind all of this information together and is thought to be implicated in being aware of oneself, emotional awareness, and being aware of one's emotions. This is a nice review article by A.D. Craig, who's really a leader in the field in terms of the biology of the insula. And we can see that it activates to a number of sensory processes, from thermal pain to chronic pain, to monitoring our respiration, to itch, to even how we feel when we exercise. A little bit of background now about the dorsal anterior cingulate. This is strongly interconnected to the insula and is another integrative brain area. In particular, there's a nice meta-analysis and review highlighting that the dorsal anterior cingulate integrates pain processing, cognitive control, emotional information. So we can think about these areas that bind a number of sensory, bodily, cognitive, and emotional processes as maybe also leading some insight into the number of physical and psychological complaints that we see in some patients with functional neurologic disorder. This brings us back to the simplified diagram that I started with, really to show that through the arrows listed in A, that the cingulate cortex and the insula have direct communications, that the cingulate cortex is connected to motor areas, and that's highlighted in B. And both the insula and the cingulate cortex are connected to the amygdala. So this circuit, in a very simplified way, is strongly interconnected and is connected to motor pathways. I'd also like to highlight that while we're in early phases of understanding the biology of functional neurologic disorder using neuroimaging techniques, there's been a lot of great work and important work already done in the field. One of the prominent themes that's emerged is that there's a hyperactivity of the amygdala, and that the amygdala, which is a core area involved in emotion processing, may be hyperconnected to motor areas, suggesting that there's heightened limbic or emotional influence over motor pathways. Another core set of findings that's been shown by several groups in the field is that not only is the amygdala interconnected to motor pathways, but there's some evidence that the cingulate cortex, that the insula are also interconnected to motor pathways, with some early phase evidence suggesting that how strongly connected these brain regions are relates to how sick patients report being, including, for example, one study showing associations with seizure frequency, non-epileptic seizure frequency. The third area I'd like to highlight is the temporal parietal junction. Less implicated in emotion processing, but critically important for body awareness and self-agency perception. And this is excellent work led by Mark Hallett, Valerie Voon, Corinne Maurer, and others. With some of this background, and there's other studies that I'm not highlighting, but are certainly also important to add into our conceptual model. But one unanswered question at this point relates to how exactly do the motor and emotion processing brain systems interact with one another? And this is a particularly important question because from a biology perspective, we don't think that there are direct connections between the amygdala and motor pathways. So might there be indirect connections that we can tease apart? Now to do this, and this is work led by Dr. Dez, we collaborated with my colleague here at the Massachusetts General Hospital, Horace Epocre, who's developed a new analysis method to understand connectivity profiles. This new analysis method is called Stepwise Functional Connectivity. And what it does is look at the information flow, the pattern of information flow from one brain area to the rest of the brain. We can think of this as occurring in steps. What's been shown in healthy subjects already in published data is that information flow from sensory motor areas converges or comes together in a core set of brain areas, highlighted in green. And I'm using my arrow to draw the viewer's attention to these green brain areas. These include the cingulate cortex, the insula, and the temporal parietal junction. These kind of higher order areas that bring together a lot of information. So we know this occurs already in healthy subjects. So we're using this exact same technique and now asking the question, how does information flow differ in patients with functional neurologic disorder in comparison to healthy controls? And I'm leaving out some details, but what we begin to observe is beginning in motor areas, there's enhanced information flow from motor areas to the back portion of the insula, highlighted with the white circles here and here. This area is involved in the physiological representation of how we feel in our body. And this occurs to a greater extent in our data in patients with functional neurologic disorder compared to healthy controls. In the second analysis, we now begin in the amygdala and ask the same question. How does information flow travel to other brain areas? And what we find is, beginning in a subregion of the amygdala that's involved in receiving early sensory input, that this subregion of the amygdala shows enhanced information flow to the front part of the insula. And this is here with the white circle. There's also another interesting finding, and that is that beginning in this sensory part of the amygdala, there appears to also be enhanced information flow to deeper brain structures involved in the stress response, including the hypothalamus and an area of the brain called the periaqueductal gray, which is involved in kind of non-conscious behavioral responses that are defensive, such as the fight or flight or freezing response. I should note that others before our group have characterized the role for these deep brain structures, potentially in the biology of functional neurologic disorder. And this is work by Selma Abeck, Tim Nicholson, Richard Cannon, and Tony David, who many who are listening now know very well. I mentioned in passing that it was the sensory part of the amygdala, the portion of the amygdala that receives sensory information, that appeared to be communicating in accelerated or enhanced fashion to the insula and to some of these deeper brain structures. Now, this is entirely our interpretation, but there's been tremendously good work done by many in the field. And one of the important findings that those of us who work with functional neurologic disorder patients clinically is that some patients report a triggering event, including physical injury or sensory experiences. And so might this be kind of a fast track between the sensory portion of the amygdala and these deeper brain structures? We're not sure. It's very early phase, but it's an interesting set of questions to maybe follow up on. The last finding that I'll highlight in this study is I've shared with the group already that the information flow, the pattern of information flow from motor areas to the insula appears accelerated in patients with functional neurologic disorder, and that the pattern of information flow from the amygdala to the insula also occurs in an enhanced fashion. Well, it turns out that in these 30 subjects with functional neurologic disorder, and I should add that these are patients with a variety of different symptoms: functional movement disorders, non-epileptic seizures, functional limb weakness. We've really tried to embrace the many commonalities that different patients share, as well as trying to tease apart some of the differences. In this particular analysis here, patient-reported symptom severity related to how information flowed from the insula to other brain areas, suggesting this might be a marker of symptom severity. We adjusted the analyses for depression and anxiety, and the same findings held, suggesting that these relationships were not simply driven by the comorbidity of anxiety or depression. So a few take-home points is I think I want to really bring the viewer's attention to one of my earlier slides, that while there's some interesting findings here, one, it's deeply embedded in a rich emerging literature by other colleagues, and two, that it very much requires replication, additional cohorts, and a number of other follow-up questions. But there's a suggestion here, based on our data, that the pattern of information flow from motor areas and the amygdala may converge in kind of an enhanced way at the level of the insula. So might the insula be the brain area that aids the communication between motor pathways and emotion processing pathways? We don't know, but that's one of the potential implications. And then secondly, does the pattern of information flow from the left insula to other brain areas? Is that something that we can replicate and show relates to patient-reported symptom severity? I want to thank my team, and in particular, really highlight that Ibaides. This was a study that really was about 12 to 14 months in the making. So a lot of hard work with several details I'm leaving out, but I'm tremendously grateful to my team, as well as a growing group of collaborators nationally. We've worked very closely with Kurt LaFrance, Mashari Keshavan over at the Beth Israel Deaconess, and a growing group of international collaborations that I've enjoyed over the last few years, including working with Tim Nicholson, Susanna Pick on that review article, and a recent collaboration with John Stone on this meta-analysis, or I should say actually systematic review. It was not a meta-analysis of the structural imaging data, which I'm leaving out of this talk, but I'm happy to take a few questions on what I've spoken about, as well as questions that may relate to topics people are interested in. And I'm very grateful for the opportunity to share our work, and in particular, immensely grateful for all the energy and enthusiasm that is being catalyzed by this webinar and other webinars that are being held this week. We have a long, long way to go, but I think that we're all energized to make a difference here. Thank you very much.
Thank you. That was fabulous. I think we're probably all trying to digest some of the information that you've shared with us, and some of the questions that I had was, how many people were in this study that you were talking about specifically on the
Yeah, it's a great question. So there were 30 patients with FND. There were 30 healthy controls. We initially started with 35 and 35, and based on things like head motion and other criteria that really we want to be rigorous about to make sure that the data is as clean as possible. The cohort was 30 subjects, 30 patients versus 30 healthy controls. So really it speaks to the fact that we're moving in the right direction. Sample sizes are getting larger, but they're not nearly as large as the populations that we're seeing in other neurologic and psychiatric research studies, where there are subjects in the hundreds. And I think that's really where we need to get to, is a neuroimaging study where we have 150, 200 subjects with FND. And that will allow the kind of power to perform statistical analyses to look at commonalities across the various subgroups, as well as we know that patients with FND can present with many different flavors or types of symptoms. And so there's nuanced differences that are really important too. And I think at this stage, we're not able to do the kind of work we need to do, given our sample size, to bring this back to the individual subject, but we're eager to do that in the future.
That's fantastic. Approximately then, how many would you feel like you needed in order to have kind of a substantial amount of participants that would help with the study?
It's a good question. What I'll say is that the analyses here are whole brain corrected. And what that means is that it's a rigorous correction for multiple comparisons. So for the kinds of analyses we've done, 30 subjects is not unreasonable. I think the first order of business is, can we recruit another set of 30 to 50 functional neurologic disorder patients and a similar set of matched healthy controls? Can we run similar and expanded analyses? And I think the first step is being able to replicate some findings so that there's consistency. And not only at our center, but replication is immensely important for the kinds of analyses being performed at other centers. So that across different centers, we can agree that maybe there's a core set of findings that we're able to really believe in and say that there is some clarity, some emerging clarity on the biology. We're not quite there yet, but I think that there's some really important leads. And I'd like to think that some of our work recently has led to some important leads.
Absolutely. I can't imagine it wouldn't. Another question is in regards to treatment. Have you had an opportunity to, after a patient has had treatment, to then look at those scans and see if there's changes after treatment to see if it was effective or not?
It's a great question, Bridget. In this particular study, we didn't do that, but we did something similar and a bit exploratory. And that is, we follow our patients longitudinally. And of these 30 subjects, 22 subjects had follow-up data. At 6 months, they completed the same patient-reported measures of symptom severity. And we found that some of the brain connectivity profiles predicted who might improve in our integrated care program that leverages physical therapy, occupational therapy, cognitive behavioral therapy, and for those who are struggling with psychiatric symptoms such as anxiety and depression, medications potentially if needed for those symptoms. Though medications in general play a very minimal role in our treatment program, and a big role for physical therapy, occupational therapy, and cognitive behavioral therapy. So the other thing I'll add, because it's important to your question, Bridget, is that what are we doing now? We're actually looking to acquire follow-up scan data. And we're doing this at a year post initial recruitment, so that we can begin to ask questions like, are these brain symptom severity relationships stable over time in the same patient? And really push the envelope in terms of trying to understand biomarkers related to prognosis, mechanisms of prognosis. And to study mechanisms of getting better, you need the scan before and after treatment. So this is work we're trying to push forward on. It's going to take us some time, but I think that this is hopefully in the right direction. And I know other groups are thinking of taking similar approaches.
It's really fantastic to see things moving to this direction and having answers within functional neurological disorder that are based on science. And I know that a lot of our viewers and members appreciate that. One question that we have that a member has asked is that they find this very exciting and out of interest, considering that this is such a fascinating and cutting edge area of discovery in brain function. Why are so few neurologists interested in it?
This
is
a great question. It's a question very near and dear to my heart. I'm working very hard to energize the community. Gosh, it's such a great question that it requires a bit of a complicated answer. I think one, I have, in doing this work, in wanting to do the best work possible clinically, while knowing that the field is very much in evolution around what are the optimal treatments. We continue to understand that month by month. I'm immensely invested in teaching the next generation, our residents, our fellows, that patients with functional neurologic disorder are patients that we can diagnose with positive criteria. This is some of the great work done by John Stone, Alan Carson, Selma Abeck, and others. And I think what the neurologists don't see as much as I see caring for patients longitudinally is that patients with functional neurologic disorder can get better. They do get better. It doesn't happen for all patients, but I've had very empowering opportunities to see patients who come in a wheelchair, who remind me that the wheelchair is now at home, collecting dust, and that they are back to work or back to school. I would like that for every patient, but all you need is a small subset of patients who are engaged in treatment, who are doing well, and that can be very energizing. And I think we have to find ways to share with our trainees and our future neurologists, as well as future and budding psychiatrists, that this is a group that one can make a career in, one can make a difference. It can be very satisfying to work in. So I think that teaching these kinds of lectures, these webinars, the new Functional Neurologic Disorders Society, that's a professional society, and I'm hoping will really further legitimize that this is a career path for very hardworking and diligent and smart neurologists to come join our teams. So we need a lot more. It's a call to arms, and it's a really, really great question. We're working hard.
Well, fantastic to see so much work being done. I know you don't have a lot of time. There's just a couple questions. I think I can kind of actually merge them into one. Based off some of the findings that you and your team have found and others, how are the scans maybe similar or different to those suffering from other illnesses, such as possibly fatigue or I guess any illness? One asked about autism possibly. Have you seen any significance there?
It's a great question. This is another direction that we need to head into. And that is that there's been a nice push up front to compare patients with functional neurologic disorder to healthy controls. I think that the next push is to begin to compare patients with FND to other populations that partially overlap. This can relate to chronic pain disorders, to patients with chronic fatigue, potentially to major depression, to post-traumatic stress disorder, across the medical, neurologic, and psychiatric spectrum of conditions. So we're beginning to do some of this work here. I'm sure others are doing it elsewhere, and this will begin to aid our understanding of, are some of these brain areas common to these conditions, and help us explain why a brain area such as the insula, that's involved in pain processing, cognitive processes, emotion processing, body awareness, it does a lot. So maybe it's a core brain area for some of these conditions that have a number of different symptoms. And maybe there might be other specific brain areas that are more isolated towards one condition or the other. We don't know these answers. We're asking these questions, and I hope that our community will be able to report back in the next few years on some answers.
That's fantastic. And I think, as you mentioned, we're asking the question, and I think it's so important that we're finally asking questions that maybe we haven't asked before because we didn't know as a community to ask them. And with all the new information that's coming out, it is exciting to see that there are changes, and there's so many great doctors that you mentioned, like yourself, that are willing to look at functional neurological disorder as an important area to study. And so we really appreciate that. We do have members asking, how they can maybe get involved in being in research and some of those projects. Are you recruiting currently for any of these type of studies?
We are recruiting currently. We recruit primarily from our clinic. So patients come into our clinical program for functional neurologic disorders, and after we assess patients, making sure that they meet criteria for clinically established FND, we begin the process of first offering patients what we know to be the best emerging clinical practices. Very much still a work in progress, but some of the consensus recommendations by Glenn Nielsen, our physical therapists, are executing best practices or good practices for PT. Similarly, for occupational therapy, we're incorporating the cognitive behavioral therapy models published by Michael Sharp with the Overcoming Functional Neurologic Symptoms workbook, as well as cognitive behavioral therapy workbooks by Kurt LaFrance. And I know that there hopefully will be even other workbooks published in the near future. So patients participate in usual care. And what's interesting is we really put a first premium on care. And in the context of treatment engagement, we then offer patients the opportunity to participate in our research if they're so interested. So the first process of getting involved in what we're doing is through a consultation in the MGH, Functional Neurologic Disorders Clinic. I should say that we're actually recruiting to hire another physician to join my group, and that is that we have exceeded our bandwidth and we're growing, and this is exciting, but we want to continue to do well for our patients, and that means we need to grow our team. So long story short is that you need to be seen in the MGH Functional Neurologic Disorders Clinic. We do not take acute referrals, unfortunately, given our bandwidth right now. But for consultations, if individuals are interested, you first need a medical record number through MGH, and that's by calling 617-726-2000. You can speak to new patient registration and be connected to acquire an MGH medical record number. After that, you can ask to be connected to the Behavioral Neurology Clinic, which is where our FND clinic is primarily based out of. And you can speak to one of our clinic coordinators to see if an appointment might be possible. We also ask that we review records before setting up an appointment to make sure that that referrals are appropriate. In general, we take mainly clinician or physician referrals. We try to prioritize that. And we're really grateful that at MGH we service a big clinical population across New England. So we have patients from New Hampshire, Vermont, Maine, and the greater Boston area really coming into our clinic and receiving services. And we hope to grow this because there's a big need to grow, and we need 3 or 4, if not 5 or 6 clinicians such as myself and a growing team. And I think this is another challenge that I'm working hard on.
Oh, great. And I just wanted to point out, because we have members in over 100 countries actually, that you are located in the United States at an MGH would be Massachusetts General Hospital, correct?
That's correct. In Boston, Massachusetts.
In Boston area, okay. And someone else had mentioned, is this being shared, particularly in Australia? And you mentioned Dr. Kanan. He is located in Australia. So there are doctors who are working around the globe on some of these scans and things, as you've mentioned before. We're really grateful for the time that you've given us. We've had a lot more than what I told you we were going to take from you. So we sure appreciate your willingness to stick around a little bit longer and go through everything. Is there anything that you feel like that maybe we didn't touch on, or that you would like to add before we go?
No, it's been a pleasure, Bridget. I'm very grateful for the opportunity. And I think I'm particularly grateful for the efforts to energize the community and to disseminate important resources. And I would advocate that your website and other websites, such as neurosymptoms.org, are great resources for clinicians. And this is important for those who are receiving care elsewhere, to direct clinicians to FND Hope and other websites, which can really be a tool to bring people up to speed.
Thank you. Thank you for your time, and we just want to remind people, if they want to tune in tomorrow, we will have Dr. John Stone talking and answering questions, just general kind of functional neurological questions, and then also Tim Nicholson, which his name's come up several times in our discussion today. He will also be joining us on Thursday, and we'll just continue on with World Awareness Week, and thank you for your time.
Thank you very much, everyone.
Thank you.